An increasingly common scenario facing pain psychologists and their patients is the task of discussing the harms associated with opioid use for chronic pain management. These conversations are almost universally difficult and can easily jeopardize the trust and goodwill that exists between the provider, who is likely facing pressures to decrease opioid use as part of the new risk management policies, and the patient, who may feel abandoned, threatened, or falsely accused by the changes. When discussions about opioid changes become necessary, the medical provider often involves a pain psychologist for assistance. However, unless the pain psychologist has an effective skill set for this type of encounter, their efforts may not prove to be helpful to either the patient or to the referring provider. This video offers a brief perspective into the psychology of opioid use and discusses conversational approaches that can foster improved dialogues between pain psychologists, medical providers, and their patients about these medicines. One of the most common pitfalls in conversations about opioid use for chronic pain is the well-intentioned attempt to educate patients about opioid risk. Backed by recent research, providers can share any number of statistics demonstrating the various harms associated with long-term opioid use. Much of the time, however, the provider will find that these education efforts have little influence on their patients. This is usually, however, not because the patient is addicted to their opioids, but instead because of the nature of our human psychology to discount information that doesn't fit with our personal beliefs. People intellectually know that money doesn't buy happiness, but they usually think that it would be different for themselves. People who are afraid to fly will believe their personal experiences about the dangers of flying over any rational statistics presented to them about airplane safety. And finally, patients are influenced far more by their own personal experience with opioids than by the results of even the most rigorous randomized control trial. Instead of trying to use education and statistics to illustrate opioid risk to patients, it is often more effective to use some of the conversation strategies shown in the next few slides. One effective conversation strategy about opioids is to make an analogy to another substance the patient may have used that might also have seemed to have helped or to make them feel better in the short term, while also being unhealthy or even dangerous in the long term. The most effective analogies to use from the list here are typically the ones with which the patient can most directly relate through their personal experience or direct observation. Modern society is now filled with examples of substances and activities that seduce us into accepting long-term risk through immediate gratification and convenience. What makes these analogies effective in part is that they allow the provider to talk about opioid risk indirectly, which usually then invokes less defensiveness and a more productive conversation. Another approach to talking about opioids using analogies is to compare opioids to several other famous medicines that were initially thought to be helpful and were even widely used, and only years later, after tragic consequences, did we learn the truth about their harmfulness. The medicines listed here were considered by most experts to be safe and collectively used by millions. Only the passage of time and the gradual accumulation of adverse events finally changed medical opinions. Precisely the same pattern is true with opioids. They were initially deemed safe for long-term use across the majority of the medical community, and only a decade of experience among millions of opioid users ultimately revealed the serious error in this judgment. When finally the harms associated with thalidomide, fen-phen, and Vioxx became clear, the same massive effort was made then that is now happening with opioids to reduce use and to lower patient risk. Like opioids, the risk produced by these analogous medicines were not the failing of the patient, but a failure of the research community and of the drug safety testing process. A third conversation strategy about opioids is to discuss them from the perspective of an advertisement. Many patients have been influenced by advertising that portrays opioids in an unrealistically positive light. These advertisements centered on desirable qualities such as rapid pain reduction, functional enhancement, personal control, convenience, and of course their low risk as a doctor-prescribed medicine. Were we to make an opioid advertisement now, however, based on recent research rather than on the goal of promoting opioid use, it might read something like what you see on this slide. Very few patients have seen opioids described in this particular way, and it can be discussed in a way that offers a combination of information and humor that tends to be more effective than efforts to educate patients about opioid risk through facts and statistics alone. particularly for patients who are new to opioids, such as those with more recently developed pain conditions or with injuries where opioids may be being discussed for the first time. The provider may also consider discussing opioid use with certain metaphors as a way of illustrating the risk-benefit ratio and the need for cautious use. Effective metaphors can be far more persuasive than educational information. The examples on this slide show situations comparable to opioid use, where the risk-reward ratio must be carefully considered in order to obtain a good outcome. In each of these 4 examples, the choice to go forward or to go in another direction requires a careful and personally tailored decision to give one the best chance of success. Similarly, in all 4 scenarios listed here, a decision that might work out well for one person might be a very poor decision for another. These metaphors, like the analogies in the previous slides, are indirect ways to discuss opioid use with patients that promote patient-centered conversations and offer non-threatening ways to think about opioid-related risk. The next opioid conversation strategy originates from a set of techniques called motivational interviewing. Motivational interviewing began as a way of having more successful conversations with alcoholics, who often became defensive and angry when confronted about their drinking. Realizing that confrontation and education rarely worked with alcoholics, therapists at the time developed motivational interviewing as a more constructive approach to having conversations about alcohol and other substance use. Motivational interviewing contains many different techniques. The present slide introduces just one of these techniques that can specifically be helpful with opioid-using patients. In this technique, the provider modifies their conversation approach based upon which of the 4 conversational strategies from the slide best fits their patients, often based on their prior discussions. As you can appreciate, talking with a patient who is rebellious about their opioid use, perhaps minimizing risk and arguing against any statistic, requires a different approach than another opioid-using patient who may be reluctant to change based on their fears and anxieties about reducing their opioids. As this slide demonstrates, skillful opioid communication requires a flexible provider who can appreciate the subtle qualities of their individual patients and adopt different conversational styles. The final 2 slides of this presentation address conversational strategies for talking about opioid use with patients who are fearful of change. Fear is perhaps the most common source of patient resistance to changing opioid doses. Despite intellectual knowledge about their long-term risk, many patients feel a high level of anxiety about the potential consequences of losing their current opioid regimen. There are several common sources of fear among opioid-using patients. Pain psychologists and pain physicians alike can benefit from realizing that these fears are usually present even when the patient doesn't bring them up. Further, unless these fears are addressed, they can act like an invisible chain between the patient and their opioid use that makes it difficult for them to break free from using them. This slide lists some of the specific fears that these patients are likely experiencing related to opioids. In the same way that you cannot talk a person out of a fear of heights, educating through fear about opioids is rarely effective. Far better is to use conversation strategies shown to be helpful in these specific types of situations. The first of these fear-specific strategies is to talk about fears directly. Fears become less intimidating when they are brought out into the open, and identifying fears shows the patient that you understand them and help you to discuss practical ways to address their concerns. Secondly, counter fears of abandonment or mistrust by providing reassurance to them that you are making changes together and will be evaluating their effects over time as you proceed. Thirdly, when a patient is very anxious about opioid changes, they are often in their heads clumping a whole bunch of different steps into one and imagining drastic and harsh changes as a result. Counter this fear by talking about opioid and pain management strategies as a more gradual process that you can outline and accomplish one small step at a time. Fourthly, the approach here called planting seeds can be helpful. For a variety of reasons, perhaps the current visit isn't the ideal or proper time for opioid changes to be initiated. However, the current visit can still be a vital opportunity to plant a seed for the future, outlining plans and the changes to come in a way that will make the later discussion seem less sudden and fear-producing. Fifth, strive in opioid conversations to be non-defensive. Roll with resistance. Expect negative emotions and don't personalize them. Acknowledge the patient's concerns and communicate your desire to help them through the process. Sixth and finally, while fears about opioid changes tend to cause the patient to focus exclusively on possible bad outcomes, there are also many upsides to decreasing opioids, especially when the patient may have personally experienced problems with them in the past. When clear problems with opioids exist with a patient, look for ways to emphasize in your discussion how a reduction in opioids may not only help to address certain problems, but also promote improvements in certain areas important to the patient, such as concentration and thinking abilities, energy levels, driving safety, sexual performance, and exercise and weight loss, among others.